My, my background, my master's degree is in human factors engineering, and I did that before I went to medical school. So I worked in system safety engineering in the transportation industry, actually, and then I went to medical school. And I always tell my colleagues that are thinking about doing something similar that the quickest way to make yourself psychotic is to first understand system safety engineering and then go work in healthcare. And so by the end of this time, I hope you see what I'm going through. Here's my goal. So we'll talk about system safety engineering. I'll give you a little bit about human factors engineering and the systems approach, which I know is already in your language. But I want to give you examples of how this can fit into patient safety. And I'll give a few examples now, and then later in the breakout, for those of you who are captured by this, I'll have more examples of how these concepts can be applied. But the fundamental thing I want to start with is talking about what human factors is, because in healthcare, 10 years ago, nobody had heard of human factors engineering, and now most people have heard about human factors, but I find that oftentimes it's misunderstood to the extent that it's sometimes thought of to be the opposite of what it is. People hear about human factors in safety, and they think it means affecting human behavior and making them more compliant and affecting the human factor in our system to do things more right. And it's actually the opposite of that. Human factors engineering is about studying and understanding the science of human performance. So what people will do well and what they won't, when they'll do it well and how they'll do it well, and then changing the system around them. And by the system, I mean, in the healthcare setting, our whole system, patient flow, the way our physical plant is, medical devices, health IT, processes that we put in place. And so if a human factors engineer who does safety engineering thinks about a workaround, where in healthcare we often are looking at workaround strategies as an opportunity for discipline and focusing on compliance and trying to get people to do it more right, human factors engineers look at workaround strategies as an identifier or a red flag of where our system probably could be optimized and designed better. And it's based on the concept that 99 or 98% of us go to work every day in healthcare to do the best job we can. We're really well trained. Healthcare providers are some of the best trained and best monitored people. You know, even physicians who have been out a long time need to recertify in boards to get credentialed in hospitals often, as you know, you have to show your skills. Nursing, same thing. Pharmacy, same thing. Hospital and healthcare workers are very, very well trained and well intentioned. People go into it for the right reasons. Now, there are some that don't. There are a few, but in my career, I've only worked with a few. There's only a handful of people I can think of that I who aren't coming to work to do the best job they can. So you have to understand that premise as we go into it, that we are system safety engineers design systems for well-trained, well-intentioned people. And I'll throughout my time with you, hopefully convince you that that's where the money is. And maybe as I talk, you'll see that we're spending all of our time and efforts on those 2%, the people that don't fit those. So I'm borrowing Lucian Leap's slide that I know you've all seen before, but I want to use it as a premise to go in to talk about why this is a problem. Healthcare is just about the most dangerous activity you can engage in. You see here it's compared to bungee jumping, driving. As an emergency physician, I'll often go into the patient's room, have looked at all say they have pneumonia, I look at all the criteria. I realize, thankfully for them, they can be treated as an outpatient. I go down, sit down with them, and they either get angry sometimes or start crying, and they say, I really think I need to be in the hospital. And I really want to shake them sometimes and say, you don't want to come in the hospital. It's the most dangerous thing you could do besides driving home, or in addition to driving home. And it's similar to, you know, the other day I was at an airport and I heard a guy got off the airplane and he got on his cell phone and called presumably his spouse and said, I'm safe, honey, I've landed. And I wanted to shake him and say, you still have to drive home. That's the most dangerous part of your whole trip. And so why is healthcare different? It's nauseating how much we hear about the IOM report, right? I've gotten to the point where I don't want to read a paper in the medical literature anymore if it starts out saying, in the year 2000, the IOM report, because it makes me think the authors are kind of still living in the past. But let's think about what's happened. What's the reason for the IOM? The IOM and the National Academies of Sciences, they all exist to influence legislation. They exist to If you look at IOM reports, usually shortly after there's legislation. And this IOM report did have a huge amount of influence. It raised public awareness of the problem of patient safety, and it also brought out a lot of funding and brought out legislation. And one of the things that happened was the government mandate that we will reduce error in 5 years. And there was a lot of funding. Actually, I graduated from medical school in the year 2000 and have really enjoyed the funding surge in this patient safety since then, so it was good timing. But is it really our goal to reduce error? I'm going to say something that might turn some of you upside down if you work in traditional patient safety, and that is that if we really want to become safer, we need to stop trying to reduce error, and we need to actually embrace it. And that's the general introduction to the rest of my time with you. So there's been no change overall since the year 2000. If you look at the statistics, now there are great pockets of change. You look at the Michigan study and how we've really gotten healthcare-associated infections in the ICU down to near zero. You look at the projects that I'm hearing about that you're doing in surgical safety here in South Carolina, unbelievably good. And I am confident that when I see that data in the end, I'm going to be citing that as one of these efforts where there's been a pocket of huge change. But if you look overall nationally, we really aren't getting better. And that's because healthcare does something that other complex, high-risk industries don't do anymore. All of them used to at some point, aviation in up to the 70s. We are focusing on individual performance. We keep beating our heads against a wall in healthcare, thinking if we can just fix that one doctor or that one nurse or make that group compliant and change their behavior, that we can become a safe organization. And this is completely inconsistent with safety science. This goes back to my psychosis and my newfound psychiatric problems that are developing slowly because I work in this healthcare environment that's completely contrary to what I learned in graduate school. Safety science is not a religion. It's a very basic foundation by which a lot of other high-risk industries are becoming safer based on. But healthcare has not embraced it yet. So I'm going to talk to you about some of the concepts of safety science. This is just to demonstrate when I'm saying we're not getting safer, I want to show you that although these are apples and oranges, these aren't the same outcome measures necessarily, but there are studies that have come out since the IOM report and editorials and people putting data together, all of which suggesting that overall in this country, we're not getting safer. And if you want the references, they're in the handout. So we need to change our focus to reducing harm, not reducing error. Think of all the patient safety articles that you read and the things that you see where it's the getting error to zero is the premise. What's one of the first lessons in life you learned from your parents when you were born? Everybody makes mistakes. Did your parents happen to say, except healthcare providers? And you laugh, but think about it. Think about the things that we do every day that are based on the premise that healthcare providers can't make mistakes. Now, I'm not getting up here saying to you, it's okay, there's a schlacky doctor working in the ER, just accept it. We can have schlacky doctors that make mistakes and aren't good diagnosticians. I'm not talking about that. I'm talking about taking well-trained, good people, which is almost all of us, and understanding that those people are still going to make mistakes over and over and over again throughout their careers. We all have, you all have, and you all know it's true. But you know it's true, but yet think about in your practice, is your hospital or your healthcare environment practicing their policy and the way that they address safety and the mission of safety with this as a premise? Or are they still beating their heads against the wall, trying to get the humans in their system to stop making mistakes, even though their parents taught them everybody makes mistakes? So if we're going to accept that errors happen, how do we reduce harm? Because I'm not saying let's just all go home and everyone makes mistakes so we can be a schlacky healthcare system. I'm saying there's a method, and there's a method that other industries have embraced, and we need to embrace it. And that is focusing on reducing harm in the setting of errors and designing the system around it. I'll give you some examples. So there's a recent study in aviation that shows air traffic controllers and pilots make an average of 2 errors per hour in their practice. 2 errors per hour. And commercial aviation, the majors, the major airlines, that's just about the safest thing you can do. If you think about, okay, my kid's getting married in a week, I don't want to die in the next week, what's the safest place you could be? Get in an airplane and just fly back and forth in a commercial airline. That's just about the safest thing. Getting in a car would not be safe. Certainly walking around. In Baltimore, shock trauma, you know what the biggest trauma they see in shock trauma? Shock trauma takes helicopters from the entire state of Maryland for all the traumas. What's the #1 frequency of trauma? People getting hit by cars, car pedestrian accidents. So just walking around the street is less safe. Get in an airplane if you want to be safe. I'm a private pilot, and I'll admit, not in a small general aviation aircraft, and not even in the regionals. The regionals do have a different safety record, and there's a good reason for that. I'm talking about the major carriers, and there has not been a major accident, there has not been a single fatality in the U.S. major carriers in 10 years. And that is despite 30,000 flights a day, 809 million passengers a year. 30,000 flights a day, takeoff and landing. Think about it next time you're nervous on a flight. What I often ask people, but I gave it away already, is what's the most dangerous part of a flight? And people always say takeoff and landing, and I say no, it's the drive to and from the airport, by factors of hundreds. So human factors engineering is not about redesigning humans. It's about saying we have a deep science to show what human performance is and what it will do. Let's design the system around that, and that will make us safe. And human factors, just the background, kind of has a backbone of cognitive science, industrial and organizational psychology, work analysis, and system safety engineering. And human factors people, in terms of formal training, come either from psychology departments or industrial systems engineering departments. They tend to think the same way, but just like you can be a back surgeon coming from orthopedics or neurosurgery, there's a couple of routes to it. I happen to come from the industrial engineering side. So I want to give you an example to now I've given you the philosophy, I wanted to bring it to life a little bit. Almost all of you in here are involved enough in healthcare in some form to know that although in emergency medicine we like to pretend everything we do matters and time is really important and it's all emergencies. But the reality is one of the few things we do that really save lives in healthcare, where every minute counts and every second counts, is defibrillation, right? So if somebody drops dead in front of me and they go into the most common rhythm that you go into when you drop dead, ventricular fibrillation, if you can get a defibrillator on them in a minute, you have a 90% chance of bringing them back to life. So that's a pretty major thing. And then it goes down 10% every minute statistically. These are old data that have always been supported. So by 10 minutes, there's no chance of bringing them back to life. So remember, cardiac arrest survival rates, I think, are a misnomer the way we talk about it, because it's not survival, it's bringing you back to life when someone has cardiac arrest. It's a pretty big deal. So let's talk about this adverse event that not only occurred in one hospital that I worked with, but has occurred in hospitals all over, maybe even in your hospital. Patient goes into ventricular fibrillation, cardiac arrest, right in front of a nurse. The nurse does all the right things, gets the defibrillator quickly, charges it up. It's within a minute, great chance of resuscitating that patient, clears the patient, and then instead of pressing the shock button, if you look over on the left screen, I'm pointing, instead of pressing the shock button, presses the on button. Now, that means I've tested lots of defibrillators. It takes 2 to 3 minutes when that happens to restart the defibrillator and recharge it to be able to get the shock. So you've lost 20 to 30% chance of saving a person's life. What kind of error is this? Was that a bad nurse? Was that somebody who wasn't trained? This nurse could have taken ACLS for 20 years. Probably this nurse is the nurse on the shift that actually tests the defibrillator every single morning. Why do I say probably? What do you do when you test a defibrillator in the morning on the nursing check shift? You turn it on, you check the battery, you make sure it's all working, and you turn it off. So what button are you pressing twice? The on button. You're pre-programmed to that, right? The expert user is the one that makes this kind of error. And there's a scientific term for that kind of error. Also, there are a bunch of human factors, design principles that are violated here. Green is our population stereotype for it's okay, go ahead, good. Red is our population stereotype for don't touch. The other thing, when this is ready to shock, this flashes, and this light is steady state. Steady state versus flash, same kind of population stereotypes. So there are lots of reasons that this error may occur, and it's not that the nurse wasn't well trained. And so why is it that we don't protect from this error? I want to go over here. Can all of you watch the left screen for a minute? I'm going to walk over here to this slide projector right here, this common consumer electronic, and I'm going to accidentally press the power button. Everyone watch the screen. Oh, what happened here? Does everyone see that in the middle? It says power off question mark. So what is that? What just happened? It's a system safety engineering protection to protect me, the user of that device, from a predictable and common error of inadvertent actuation of the power button. So unless I'm missing something, I don't think that I can kill a patient or hurt a patient by inadvertently powering down a slide projector. Yet universally, every single slide projector company that I've ever worked, seen, or touched has this protection built in. So the consumer electronics company has said, this is a common error that's going to occur. It could have an adverse effect if somebody's giving a presentation and it takes time to power up the slide projector. So we're going to protect the user from that predictable error. Why didn't this consumer company try to reduce non-compliance with the policy not to power down when you shouldn't? Why didn't they try to train all the potential users? That's what we would do in healthcare, right? Or maybe we would put a label up. Certainly, we would definitely do an in-service policy and have the nursing educator on every unit have all the nurses signed that they were told not to power down the slide projector. That would be healthcare's solution to this problem. You're laughing, but you know I'm right. Why is it that a consumer electronic company is better at protecting us from a misuse of a device than we in healthcare are? And the answer is because in healthcare, our basic premise is the answer to safety is having people never make errors. That's our answer to safety, and that's what we're doing wrong, and that's why we're not getting safer. So sometimes, by the way, I love to give this example. I always give it, but sometimes I can't get to the slide projector without climbing on tables, so I have to have a picture just in case. So we found this when I was involved in an EMS safety system. We had 3 firefighters report that they had done this. Sometimes they reported that the defibrillator didn't work. Then we sent it to the defibrillator company, and what did that come back with? Operating as intended, right? Or operates as specified. That's a big signal for a human factors user problem, usability design problem. So then we published a usability study that included information about this, and somebody in Denmark read it, went back and looked at their data from a simulation study they had done using physicians, and they found in the 192 defibrillations that had occurred in their simulation, 5 times this occurred. So not only is it a predictable error, we have data to show us it happens regularly, and since we published this, I hear about it all the time. So this is a great example of how we think we're going to fix the problem by training people when we should fix the problem by designing a system. Now, many of you may be thinking, well, I can't redesign a defibrillator, and that's true. You could push back. You can get your buyers to count this kind of stuff. But this is an example, and there are lots of other examples of things that we can change. So there's a science behind this, and you're going to hear later from Josh, who's going to talk to you about the value of training. And there's definitely some areas of safety where training is the answer. So I want to just show you the distinguishing factor. Probably many of you have heard of the error classification that Jim Reason used in his first book. It's called SRK, Skills, Rules, Knowledge Base. It actually comes from a theory by Rasmussen, who used it before Jim Reason changed it to error. Rasmussen talked about the different cognitive ways we operate. And the 3 levels have different kinds of errors. And the reason this is so important for us to understand is the lowest level, the automaticity level at the bottom, which Jim Reason calls and Rasmussen calls skill-based error, which I hate to use in healthcare because people always think skill-based means intubation or technical skills, and it doesn't. Skill-based, think of it as automation, when you're in the automatic mode, and I'll give you a good example of that in a minute. But Knowledge-based is when your errors are from trial and error. Actually, knowledge-based is often the way that you learn to do things well is through trial and error. And that's where training can really have a huge impact, because you don't want your providers to learn something for the first time by trial and error. So when you're talking about teaching nurses how to lift correctly, you don't want to wait till they've hurt their back. You want to train them the right way to do it. Rule-based is protocolized behavior process where people follow things. And the errors that can occur there are misapplication of a good rule, not applying a good rule, and that's where compliance can come into effect, or applying a bad rule. But the vast majority of errors in healthcare are slips and lapses. What I just showed you was a slip. That nurse didn't intend to press that button. The nurse knew the right button to push, and yet they pushed it. And this occurs when we're in automatic mode. When we're in that cognitive mode, things we're not thinking about. So a new user of a defibrillator would not make that mistake because they would think about every step that they're taking. And by the way, the answer is not to just tell everybody to think more. Because we're all in automatic mode. You can't change when you're in automatic mode. This is just a function of your experience, and it's one of these human factor realities that we have to embrace. Skill-based errors are when you're in the mode that you could do without a lot of attention. And I'll give you a really good example of that after one more defibrillator example here. I'll give you a non-medical example. So here's a second defibrillator case, and I'm not picking on defibrillators. It's just earlier in my career, I did a lot of studies and work with defibrillators, so I have good examples here. But also, I think they make great examples for demonstrating these problems. So a 32-year-old healthy guy comes into the ER. He has a rapid heartbeat. He's in SVT, which is a non-life-threatening heartbeat. It's a really fast heartbeat, but it's not going to degrade to your heart stopping. So you have a little time, but the standards say if they have chest pain or other complicating factors, you should shock them rather than give them a medicine. The only key about this shock, by the way, is there's two kinds of shocks defibrillators do. To simplify it, I say you do one on dead people and you do the other on live people. If you do the one you're supposed to do on dead people on a live person, there's a good chance you can kill them. So you don't want to not press that button, and that's the button synchronized mode. Some of you may have heard. So this should be a synchronized shock because the patient's alive. And the reason for that is it synchronizes with the heartbeat, because if you shock somebody at the wrong time in the cardiac cycle, you stop their heart. And that's not good for patients. So the doctor does the right thing, presses the synchronized button, shocks the patient, and then it doesn't work. So did the right thing. This is normal. You have to upgrade the power level. You start low so you don't hurt the patient as much when you're shocking him. You go to the next higher level. You press the button again. It shocks them. They go into cardiac arrest. The patient dies. This is a true story. It's one true story. I can guarantee there's a true story like this at every hospital in the entire country at least once. Because here they found the physician did not put the device back into synchronized mode for the second shock. Now, in our traditional model of patient safety, this would be pretty easy, right? Failure to follow protocol, failure to meet standard of care, physician gets retrained, if it's a nice hospital. And then, by the way, make sure all the other physicians in the specialty sign a thing or take a video or something to make sure they know how to do it. What's the problem with that in this case? Did the physician know the right thing to do? How do we know that? Because they did the right thing, right? So it wasn't that they didn't do the right thing. This was probably a very experienced physician. A lot of physicians do synchronized cardioversion all the time. But what do most defibrillators do when you deliver a synchronized shock? They come out of synchronized mode. So this violates every standard. There are textbooks written in the 1970s about automation and about human interface design of devices, and this violates all of them. Because can you imagine if when a pilot, you know why we use autopilot, right? We use autopilot not so pilots can drink coffee, but because at certain times in the flight, the task load outweighs the human processing ability. So autopilot's really important. Can you imagine if you were in autopilot on a final approach in the clouds where you couldn't see anything, and you change the altitude, and the autopilot just turns off, but doesn't tell the pilot it turns off? This is the equivalent. This is a change in mode without any communication with the user, without any active communication. And this is a design flaw that has hurt a lot of patients. And it's based on the premise, this isn't to blame the manufacturers. We are at fault. Healthcare is at fault. Nobody's asking for more system safety because we're basing the design and we're basing our response to adverse events on the premise that we're going to rely on the person to do it right next time. I guarantee you most hospitals in the country, when they have this adverse event, would be counseling the physician. That would be their response. And that's the wrong response. We're not going to get safer. When we did this study, we showed 71% of participants were never even aware that they made this, and 50% of the people who were experienced defibrillator users made this error. It's a very common error out there. Look back in your hospital at synchronized cardioversions that led to cardiac arrest, and I bet you'll find one of these. So we have pursued this, and here are some of the responses that we've gotten. One case was a cardiologist. We have lots of cases of this. One case was a cardiologist that came down to the ER, and the response from the manufacturer in writing was, the physician should have taken the time to ask the ED staff for an operator's manual for the defibrillator and read it after he arrived in the ED to perform a cardioversion. How many people use defibrillators? Raise your hand if you use a defibrillator. Okay, it's a good number. Leave your hand up if you've ever read the operator manual to a defibrillator. One person. Excellent. You must be a biomedical engineer. So this is not the reality. And part of human factors is designing for the reality of the working environment. We don't have an environment where people can read a defibrillator operating manual before they defibrillate a patient. And let's transition to device labeling. Right? This is a very common system safety approach in healthcare, is labeling. Let's talk about labeling for a minute and frame it in the skills-based, rules-based, and knowledge-based framework. How many people think labeling will work when you're in automatic mode? Well, let me give you a good example that you've all experienced. How many people in this room have ever not walked up to a door and pulled when you should have pushed or pushed when you should have pulled? Nobody raised their hand. So we've all made that error, right? What mode are you in when you approach a door after you're about age 3? You're in skills-based mode. You're in the automatic mode. Your brain is not thinking as you approach the door consciously, that door has a pull handle, so I'm going to pull on the door. Nor does your brain think, well, this is a public building, that's the exit, so fire code requires it pushes out, so I'll push when I get there. What's actually happening in your brain is your brain is taking unconscious visual cues from your eyes, and you're seeing that it's a pull handle. And when you're in automatic mode, your brain uses past experience, and it tells you what to do. So you get up to this, and you pull. Sorry for those of you looking at the right-hand screen. This pointer's in my right hand, so I know I'm favoring the left-hand screen for you. But the pointing really isn't helpful. So this is a bagel shop near my house. One day we were in this bagel shop, really crowded, and the kids, they're 7 and 10, they started to get really cranky waiting in line. They were hungry. So my wife stood in line. I guess we voted or drew straws. She stood in line to get the food, and I went to the back of the bagel shop to wait with my kids. And I watched customer after customer after customer go up to this door and pull on it. But look at this, though. What is right in front of their face? Literally right in front of their face. So this is a community bagel store. It's probably people who have been there over and over and over again and have made this mistake over and over and over again. There is a label as big as my head right in front of their eyes telling them to push, yet they're all going up to it and pulling. If this were healthcare, we would have them all, first of all, we would put a policy in place and put it on the binder shelf on the nurses' unit so that when Joint Commission came by, they would see that we had indeed addressed this problem. Who's the only person besides the Joint Commission that benefits from a policy after this adverse event occurs? Is the plaintiff's lawyer the next time that the same adverse event occurs. Because now you also have a policy violation, right? Changing policy, educating people is not the way to get people to use this door, right? It's change the door plate. Make it a plate so that their brain is communicating to push. You can use this analogy in thousands of things you do every day in safety and healthcare. Think of the most obvious, drug labeling, right? It's not just the labels being different, But why is it that the same exact vial that looks the same, feels the same, is used for drugs that can be pushed through the IV after they're drawn up, and drugs that will kill somebody if they're pushed through the IV when drawn up, and should only be mixed and given as a drip? Why are those the same? Well, the answer is because in healthcare, our answer is that we'll maintain safety with those similar things by making sure that we have a culture of accountability and tell the nurses not to give the wrong drug. Now, if I instituted 5 rights for you approaching this door and told you you need to think about it, each thing, how much a reduction, that would probably reduce it, right? The people leaving this bagel shop, not as many of them would pull. Would it bring it to 0? No. So it's not the way to bring things to 0. There are lots of cases here. I love this one. On the left here is the back door to the OR that no one uses. On the right is the front door that everyone uses. You can see where the where is. They're following the rule. It says to exit, press here. Someone put an arrow in. What? People send me pictures all the time. You're all going to start taking pictures now with your iPhones and putting them in your own slide presentations. This is one of my favorites. In an ER I used to work in, this was the latex-free room. It says, please stock latex-free gloves only. Almost 100% of the time it was stocked with latex gloves. Why? Well, there's a couple of reasons. We missed an opportunity, right? If we bought the latex-free gloves from a different company so that the boxes wouldn't fit in that dispenser, we'd have a forcing function instead of relying on human vigilance. The other is, who stocked the rooms? It was the people with the least medical training and understanding in the whole ER. Well, this is what the box says, powder-free latex. Free latex right there. Powder-free is what they mean, but these people often, when I talk to them, a lot of them thought those were the latex-free gloves. But how have we done? We've done a good job with this in healthcare, right? We have solved this problem. We have a system safety engineering solution to this problem, and what is it? We don't have latex gloves anymore, and that's a great way to reduce a huge hazard. Well, Christmas tree, it says air, that says oxygen. It's very clear, it's yellow. Yet, how many people that work in a clinical environment have not seen this problem at some point? I've had multiple times where a nurse calls me into a room because a patient on oxygen is having trouble breathing. I go in and I find this. And it's because these two fit. The green Christmas tree fits on the yellow oxygen, and so you take away the visual cue, and when people are in automaticity mode, they put it on a green Christmas tree like they're used to. It's all skills-based error. This is where we live in patient safety. If you look back at your major events, you will find skills-based error in almost every single one. And yet we're not addressing them with effective solutions. We're addressing them with solutions that would be effective for rule-based error or knowledge-based error. We're not addressing them for skills-based error. So slips and lapses are the most common in healthcare, but policies, in-services, discipline, training, and vigilance, being more accountable, does not work in slips and lapses or skills-based error. That's the one key principle I want you to walk away with today. Certainly there are sometimes other kinds of errors where those things work, but in the most common type, they don't work, and that's what we're misapplying. The irony is, that was the title of the book. That was the title of the report in 2000 that we really haven't gotten yet, and that is To Err is Human. We can't take humans out of healthcare, so we have to design around humans. So accountability is important. For example, if we know that a surgical safety checklist is going to make us safer, and we've implemented a policy that every surgeon has to do a surgical safety checklist, then accountability is a good answer, right? But it's not safety. It is an intersection. I like to show in healthcare, we've got the pendulum swinging towards believing that if we just make everyone accountable, we'll be safer. But see the problem with skills-based error? It doesn't help. The real way is to think about it as an intersection. Safety, and the people concerned about safety should be focusing on skills-based error and errors that aren't accountable out. And then accountability is an administrative function. We can't put all of our eggs in the accountability side. If there are surgeons or anesthesiologists or others in the OR who are not willing to go with the new policy and do it, then that's an accountability issue, but it's not the patient safety officer's issue. It should be an administrative issue that's dealt with separately. So in my breakout session, I'm going to break down, what I'm going to do in the breakout session is bring these more to life in healthcare by doing RCAs of specific cases with you. And this is one of the ones I talk about, but I just want to make the point, almost all of you are probably familiar with the case in Indiana where in the NICU, six patients were given the wrong heparin. Instead of the low-dose Heplock, they were given the 1 to 10,000 one that should only be mixed. And 3 of them were killed, 3 of the babies were killed, and the other 3 were injured. But here's the thing. 5 different nurses gave those medications that day. The wrong one had been stocked in the automated drug machine, and 5 different nurses gave it. If that's not a demonstration that the answer to our problem is not fixing the person, I don't know what is. Clearly, this is a system problem. And I have to say, Clarion Health deserves a lot of credit because that day, before they even had any idea what had happened, the CEO was in front of the media saying, we don't know what happened yet, and we'll get to the bottom of it, but one thing we do know, this is not an issue of personal blame. This is a system problem. And that was in 2006. The single greatest impediment to error prevention in the medical industry is that we punish people for making mistakes. Lucian Leape said that years ago. So this is not new. Human factors people in aviation and the nuclear industry have been doing it for years. By the way, some of you may be thinking, we're not aviation, we're different. And I gave a talk last year at NPSF with a pilot talking about the connection between aviation and healthcare. And when I was preparing for it, I called human factors engineers that I knew that had made their career in aviation. And I asked them, what is the similarity and the difference from your perspective? And one of my favorite answers was from Colin Drury, who's a very well-known human factors person that made aviation maintenance safe. And he said, well, the biggest difference is that in the 1970s, when we were trying to make this change in aviation and we were using the nuclear industry as a model, they all said, it's different, we're not the same, you can't apply this to us. And he said, that's the biggest similarity, is that's what we keep hearing in healthcare. So sometimes when I talk about this, people think it sounds a little soft. Some people, up till hearing this, have really believed that accountability is the answer to safety. And so there is a way to kind of, there is an intersection between the two. And I know all of you know just culture and talk about it, and I'm not going to go into a just culture lesson, but I want to make the point that the way to change the culture in your hospital is to have your senior leaders and your middle managers understand just culture first, then roll it out to the troops. Because what happens a lot of times is it's rolled out to the troops, but the nursing unit managers don't get it. I can't tell you how many times I've gotten to the scene of an adverse event, and the nurse has already been walked down to HR and suspended by the time we even get there to review it. So this just culture frames everything I've been talking about so far. When there's an adverse event or a problem that occurs, it asks, is this reckless behavior? And that's on the right. And if so, punitive, right? Reckless behavior. But that is so unusual in healthcare. Almost all of what goes wrong in healthcare is not reckless behavior. That's why we're misdirecting a lot of our focus when we're talking about fixing the people. Most of it is either normal error, which are most skills-based errors, and at-risk behavior. Now, both of them are not punishable. Both of them in the just culture idea are coaching and learning from them. And why is it that at-risk behavior, maybe workarounds, maybe taking a little risk, should be coached and learned from and not punitive? Right, they don't see the risk, number one, exactly. So it's not something intentional. And number two, oftentimes it's their environment and the system they work in that leads them to need to do it. Like a nurse who gives meds early because in the 11 o'clock to 1 p.m. time frame that you're required to give a noon med, they can't possibly do it. If you look at it with an industrial engineering model, they couldn't possibly do every med, and so now they're forced to find shortcuts. So we need to look at those at-risk behaviors, workarounds, and shortcuts as system people and try to figure out why they're doing it and then help change that system. If you're interested in just culture, I do really highly recommend Sidney Decker's book. I think it's one of the best weekend reads you can get. It's not thick, heavy reading, and I would take it on vacation. You won't be sorry. There's lots of great stories in it. So why is this culture of safety so important? Why is it important to create a just culture? And the answer, this is old data, but it's always been repeated, is that for every adverse event, there are 600 near misses. One of the other things that we're not doing well in healthcare is we respond differently to an event that has a bad outcome than we do to an event that doesn't have a bad outcome. It's the same risk to future patients. The same risk to future patients, whether or not we've hurt today's patient. And so we need to focus on the 600 incidents. Right down here is where our focus should shift to. How many people, don't raise your hand, but I'm just asking this rhetorically, how many people in your institution's event reporting system does all of the ones that injured patients go to all the senior leadership automatically, but none of the near misses do? How many people trend their near misses and look for high-risk things and trends that are occurring more often and treat those the same way they do an adverse outcome or a patient death? That's the way that we can make a difference with this kind of thing. And we'll only hear about these if it's a better culture. If people feel like it's punitive, they won't report. If people feel like they write an email and say, I just came in the office, I was on vacation last week, and I got a message from a patient for the Friday afternoon after I left in the EMR that sounded like an emergency and nobody saw it. And then they get a letter back from the administrator say, you need to make sure you recheck your EMR at the end of the day. Putting it right back on the human performance part instead of looking at the system. Then the culture is done. They're not going to be reporting anything else. Whereas that's a good predictor of a near miss. That was a use error. I just pressed the mute button. By the way, that user error versus use error, a use error occurs from poor design, and a user error really is a non-existent phenomenon. So we're focusing on the one major injury. If we start focusing on the 600, now we can't fix everything in our event reporting system. We can't fix every near miss that we hear about, so we have to triage it. We have to look for what's going to be most likely to occur and fix those, and what is, even if it's a rare occurrence, going to be a very, very bad outcome. So you look at the high-risk things, the things that will cause a patient death. Even if it's not that common, fix that. And you look at the high, even if it's not going to cause a patient death, but it happens more often, you fix those. The other things you can let drop. So I'll give you one example of how this kind of approach can help. So we're all dealing with trying to do VTE prophylaxis, have patients not have PEs. And it's a little complex because different patients get different levels of VTE prophylaxis. And so all of us have been dealing with that around the last 5 or 10 years, right? So here is a protocol from a hospital that's the policy of how to VTE prophylax a person. And at the time this policy was on the books, the physicians who do admission orders, who are responsible for choosing this, most of them had never seen it, right? But it's in there and they're held responsible for it. So they did a good, when they were starting to do the push, they said, let's educate everybody on it, and we'll put it in the front of every chart so it's right there for reference. And this hospital, I happen to know, 99.9% of the physicians, 99.9%, are really good, well-meaning, well-trained physicians. So this compliance problem probably has a lot of other factors other than them just being bad people, right? So 50%, they put in this in every chart, and they did a big education campaign. It went to 66%. So there's two avenues you could take at that point. You could enforce compliance, or you could investigate and figure out why. Why is it not going right? And this audit was about the correct prophylaxis, not just any prophylaxis. So they had to pick the right level. And what this hospital did is they put, and you can see this, they have an old CPOE system, they put a pathway into CPOE that just had 3 quick screens that the physician had to answer. The system knew how old the patient was and knew other internal factors, so it only had a few questions about the type of procedure, the kind of risks that the patient had, and then it classified it automatically in the background, and then it told the physician what the recommended dose was. And because of reality, of course, there had to be a number of other alternatives for the specialties that were special, and but they had to do it in an evidence-based way, but all of them met criteria. And then you click on the button, and it puts the order in. So it made it easy for the physician to do it. It fit in their workflow, but there was a forcing function. Unless you did the emergency bypass, which was audited, you could not admit a patient without going through this pathway. It was allergies and this were the only two mandatory pathways. Now, it's a balance, right? We can't do mandatory pathways for everything, and sometimes it could be a slippery slope. But here it worked really well, and it brought the compliance to 93%, and the other 7% were all appropriately documented as reasons that they weren't the right prophylaxis level. So it really, in effect, brought it to near 100. And this was a good success story of not focusing on trying to discipline or educate, but just making it easy to do the right thing, putting it in front of them. Because if you look at that paper protocol, it's impossible to do the right thing. So to be safer, we need to develop sustainable solutions, not ones that are only in place 3 months after the patient was killed and everyone's thinking about it and everyone knows they're being audited, but something that's there 1 and 2 years later. We need effective solutions. Effective solutions are those that hit the type of error that occurred. And that's challenging because first we have to figure out the real contributing factors. I like calling them that rather than root causes. Real contributing factors. Then we need to find out what kind of error was involved and design the right solution to address the right error. And if this sounds complex, it is. But one other difference is aviation didn't become safe, for example, by getting a room full of pilots and nurses in a 1-hour lecture on system safety engineering. They hired, when I was in graduate school and I was graduating, almost all of my classmates went into the aviation industry. They were hiring so many safety engineers. And so one thing that you can do to help with this is to partner. Every community has people that do this in some form. Industry has a lot of them. Partner with somebody to help. And we need to consider solutions in context. And I'll talk about in the breakout session the idea of complexity and how in a complex adaptive environment, there's a big gap between how administration thinks the work is done and how the work is really done. And we really need to study that difference and make our solutions in the actual context of the real work to make them safe. And finally, we need to focus on hazards. We're too focused on adverse events. I'm not saying they're not important. We definitely need resources. We need to look at the second victim. We need to make sure the healthcare providers are okay. We need to take care of the family. We need to do the right thing for them with early disclosure and all that. But we also need to be focusing on the hazards. Otherwise, we're not going to get safer. We're just chasing our tail. And to give you a little preview of what I'll talk about this afternoon, I use the model of the prevention of heart disease when I try to talk about how we're focusing our efforts in the wrong place. So for those of you who don't know the model of heart disease prevention, there are 3 stages. There's early prevention to keep patients from getting heart disease. So early on, teaching them to eat well, not smoke, not have high blood pressure, and to exercise. Secondary prevention is what occurs once they have heart disease. We screen for their risk factors, we control their risk factors, put them on cholesterol medicine, and we try to keep them from having a heart attack. And then tertiary prevention is after they've had their heart attack, we try to minimize the comorbidity, minimize the effect, put them on beta blockers, get them rehabilitated. If you think about this and you compare this to healthcare, all of our focus is on tertiary prevention in healthcare. We're not thinking about preventing an error from, a hazardous condition or an unsafe condition from even existing in the first place. And that would be primary prevention of safety events. We're not thinking about secondary prevention. We are a little bit, but not enough. And that is identifying the hazards, the unsafe conditions. And in hospitals, if you go around, usually after an adverse event, many of you have had this experience, you go to the nurses or the doctors on that unit and they say, we could have told you this was going to happen. This made us nervous all along. People know where the hazards are. But our culture doesn't allow them to talk about it, and we're not focused on fixing hazards until after they become adverse events. So we need to shift over to the left to the primary prevention if we're going to really make a difference. That's where the money is. That's where 90% of our work can be done. So these things you've heard me say, I won't read the slide to you, but you get it. This stuff will not reduce our risk in the future when we're talking about skills-based error. We really need to focus on the unsafe conditions, find effective and sustainable solutions. And I'll end with Jim Reason's quote, Fallibility is part of the human condition, and we cannot change the human condition, but we can change the conditions under which people work. And that's what we all do for a living. We try to change the conditions under which people work. That's how we're going to become safer. And to tie into Ian's introduction, that'll reduce cost dramatically. So if you like this stuff, here's some things. It'll be in the handouts, so you don't have to write them down now, but some really easy reads with asterisks, which I think are fun to read, and then there's textbooks to put on your shelf and refer to that I'm listing there too.